Okay, we are now live on YouTube and ready to begin. And before we begin, I can confirm that we are quorate for this meeting, although we've had a number of apologies. So I do wonder whether COVID and meeting in person for the first time may have had an impact on us, but we'll see. So first of all, apologies, and I have apologies from the Chair, Councillor Poulter, who's in a levelling up meeting, so has asked me to chair, and I've got Andy Smith and Councillor Williams, who are both in a Safeguarding Children's Joint Derbyshire Board meeting. So that's them, and then we have...
I've got apologies from Councillor Martin, David Cox, Helen Dillistone, Merrill Watkins.
Thank you. And on the subject of Merrill Watkins, this would have been her last meeting as Vice Chair of the Health and Wellbeing Board, and Merrill and I set the agendas for these meetings, and I can say that her help has been invaluable over the past couple of years when we've been doing this. So I would like to pay thanks to her, even though she's not present at this meeting. Okay, if we can then move on to late items introduced by the Chair, and I have none. And are there any declarations of interest? In that case, I'll take silence as none. And can we go to the minutes of the meeting held quite some time ago, 29th of July 2021, and can they be accepted as a true record? Okay, we have Vicky who said yes, and Stephen who said yes. So are there any matters arising on those minutes that won't be dealt with on the agenda?
Look, Chair, there's just a couple of actions that I need to take forward. There's one around Drinkaware, so we just need to contact those and check where their status and look at them coming to a future board. And also I think we agreed at that meeting that we'd have an update from the Poverty Commission at a future meeting, so I'll add that to a future agenda.
Thank you, Alison. And next item is item 5, and that's Vicky Taylor, and it's Joined Up Care Derbyshire update. Over to you.
Thank you, Chair. Can I just check that everyone can hear me? Thank you. Okay. So thank you very much for the invite to provide an update on the development of Derby and Derbyshire Integrated Care System. Would it be possible to have the next slide, please? Thank you. Oh, thank you. So just in terms of some context, which I'm sure looking around the room, a number of colleagues will be all too familiar with. However, the government set out a proposal to progress local partnership working arrangements between health and care partners, and as well as broader partners, onto a statutory footing, and there were some early engagement documents back as far as 2020. As subsequently there's been legislation, there's been a health and care bill, and there is legislation going through Parliament at the moment. The second reading of that bill and the draft legislation is expected to happen in April of this year, and that, if approved, will result in integrated care systems becoming statutorily recognised arrangements across England. there has been, colleagues may have picked up from what I've just said, that the July 2022 commencement date, that's a delay of 3 months from the original plan, which obviously was April 2022 for commencement of statutory arrangements. And that delay as a result of delays in the legislation going through Parliament. But we within Derby and Derbyshire have taken that as a positive opportunity to further build the work that's happening across the integrated care system. So subject to the passing of the legislation, the arrangements of the integrated care system will comprise essentially of 2 main component parts. So the first will be the Integrated Care Partnership, or acronym ICP, which colleagues may have come across, which essentially is a broad alliance of organisations and partners who come together collectively to focus around improving care, health and well-being of the population. That Integrated Care Partnership, or ICP, is jointly convened and run by local authorities and the NHS. And I will come back to that shortly. The other component part of the arrangements are the establishment of the Integrated Care Board, or ICB. That body, the ICB, Integrated Care Board body, will replace the current Derby and Derbyshire Clinical Commissioning Group, or CCG, which colleagues may be familiar with. That will essentially be the responsible body for bringing the NHS together locally to improve population health and care. So they're really the 2 component parts of the new statutory arrangements that will come into place. Colleagues will be aware from previous updates I've provided that there are 4 nationally defined core purposes of integrated care systems, which are on the slide, but essentially focus around improving outcomes in population health and healthcare, tackling inequalities, enhancing productivity, and supporting broader social and economic development. So how have we got to this point within Derby and Derbyshire? So colleagues will also be aware that Joined Up Care Derbyshire, JUCD, is the local name, local brand that we've used to describe our integrated care system. And we're really not starting from scratch with this change that's due to take place on the 1st of April. This is something across Derby and Derbyshire we've now been working towards over a number of years, and in terms of building, maturing local partnerships arrangements. And very much focused on engaging with partners to make sure that with this legislative change that's coming, that actually we take this real opportunity to refresh the way we're working collectively and to make sure that we can really address that core purpose that I've just described. You will see that on the slide that the purpose of Joined Up Care Derbyshire very much mirrors that I described as the national expectation in terms of really focusing on tackling inequalities, enhancing productivity, and really thinking from an NHS perspective, what can we do as a collective of NHS organisations, because we are significant employers, have an influence over the local system and support to people in communities. What broader support in terms of social and economic development can we offer to help address some of our partners' objectives as well, so perhaps the council's objectives, etc. So what's our contribution to that? So that's quite a big focus, which is a different focus than we've perhaps had historically. Next slide, please. Thank you. So described previously the two key components of the statutory change, which is around the establishment of the Integrated Care Board and of the Integrated Care Partnership. I think it would be remiss absolutely not to mention what I would view as being of equal importance to those 2 component parts, which are the development of provider collaboration at scale, which is bringing together of provider partners within Derby and Derbyshire to work together to look at opportunities to improve the way that services and support is delivered and offered to our population, and also place partnerships, which colleagues here will be very familiar with, but is very much about services being provided within communities with people very much at the heart of those services, and looking at how we can better integrate the way we work to achieve better outcomes for people. Next slide, please. Thank you. So in terms of some of the progress on this transition that we've been undergoing, I think first thing important to confirm that we are on track for developing and establishing all of the key component parts that I've described that make up this integrated care system. We've also had, I suppose, the approval in terms of where we are in our development from both regional and national oversight bodies such as NHS England and NHS Improvement, who are content with where we are in terms of our work that's underway. We are focused on continuing to build the sort of strong system collaborative approach that's, I think, particularly developed and strengthened through this COVID experience over the last 2 years. In terms of the Integrated Care Board and the establishment of that, which, as I said, replaces the Clinical Commissioning Group, the chair, designate chair, Chief Executive Officer and non-executive members have now all been appointed and confirmed, earlier this week we confirmed the appointment of a number of the executive directors and the remaining posts that will be going out to national advertisement. So that's progressing. In terms of the Integrated Care Partnership, the inaugural meeting took place on the 28th of February. Was, I think, from feedback we've received, really positive first meeting and gave an opportunity for partners to come together and really have shared responsibility and shared sort of co-development of the Integrated Care Partnership arrangements moving forward. I think probably one of the other things just to reference, although not directly impacting Derby City, but it is part of the broader integrated care system development. Glossop will become part of the Derby and Derbyshire integrated care system and part of the geography from the 1st of July, which is obviously something new that will happen, and we're working with partners very closely in the Glossop area and broader sort of Manchester oversight system to support that transition and make sure that it is as smooth as possible for and hopefully people who live in that area will see the benefits of collaborative working across Derby and Derbyshire in terms of the services that are offered to that population, and we'll have the opportunity clearly to engage in sort of helping to develop and improve some of those services moving forward. And then finally, because whilst, as I've said, the statutory developments are important, the development of providers working more collaboratively together will actually, I think, be the biggest thing that makes a difference for our local population. And so I wanted just to flag the work that's happening under the umbrella of Team Up work, which is very much about local provider partners coming together under the primary care networks to work collaboratively to support housebound people in their own homes through better coordination of care and support to avoid, where possible, hospital admissions. So I think that's one of the real benefits of this transition to an integrated care system. So I just wanted to flag that as one of the key developments that's happening and is progressing well. So I hope that was a helpful update. Thank you, Chair.
Thanks, Vicky. For those of you who've not heard this before, and there's a lot of local members in the city that haven't heard all of that information. There will be briefing sessions for councillors coming up very shortly. With regard to the Integrated Care Partnership in the first meeting, a very good meeting, a very long meeting, and to show the collaboration, it was chaired by my colleague in the county, Councillor Carol Hart, who is chair of the Health and Wellbeing Board in Derbyshire, and that does show the true collaboration. I think I'm due to chair in 2 months' time, and then there will be John MacDonald, who is from the health service side, who will chair that later on. So it really is true collaboration between local authority and the NHS. So thank you for that update, Vicky, and I wish you well in keeping things going to meet the July target. Okay, any questions? Yes, Stephen. Lift your lid up. That's it.
So, thank you, Chair. And just to reinforce what Vicky was saying, really, about the partnership and the collaboration work, certainly from a Teams Up perspective, I can endorse that the local authorities and the health partners come together and are really working extremely positively across Derbyshire, both at a Derby City and a Derbyshire County level. And I've been leading some of the work on the provider collaboration at scale, and initially that's been quite health focused. But we did discuss with local authority colleagues whether they wanted to be involved in that initially, but their focus was primarily at the place-based partnerships in both Derby and Derbyshire. So that's the initial focus, I think, from a local authority and health partnership. But certainly in the future, the provider collaboration at scale work is actually looking at bringing in health and local authority partners to look at that at scale across the whole of Derbyshire. Things like children's services, which is happening across other parts of the country at this moment. And I know Andy and Helen have been looking at what's happening outside of Derbyshire and Derby City in terms of that work. So just conscious of that work going forward as well.
Thank you. And yes, that collaboration and the work around health inequalities, that's something that we in local authorities are looking to improve on, and working together, I'm sure we can improve outcomes for everybody across Derby and Derbyshire. Thank you. Anybody else? Okay, well, thank you for that, Vicky. And we'll move on to Robin Dewis, our Director of Public Health, who will give us an update on the Outbreak Engagement Board.
Thank you. So, yes, I've got an update. Linz, would you mind the next slide? Fantastic. So what I'm going to cover today is an update on COVID, which relates to the Outbreak Engagement Board, and also on the Derby and Derbyshire Health Protection Board. For those with long memories, it feels like a long time since we've talked about that. So just to run through from a COVID perspective, what's happening with national policy, what's happening with our local data, and sorry, Linz, would you mind just going back to that's it. And what we expect to happen over the next coming months, and then a quick summary through of the Health Protection Board and the work plan of the Health Protection Board. Thanks. So from a national policy perspective, we've moved from all of our actions to prevent spread of the virus towards protecting the most vulnerable. So very much focused on those people who are most vulnerable from COVID, who remain people who are unvaccinated, but also people who are older and people particularly who are immunosuppressed due to either a medical condition that they have or medical treatment that they're receiving. So we've moved away from the legal requirements, but we do still have guidance in place. So individuals who are known to have COVID are still advised to stay at home in the same way as they were previously legally required to do. And we still have advice around hand washing, keeping our distance, and wearing a face covering when we're in crowded areas. So all of those advice areas still stand, but there aren't any legal requirements around them anymore. We've also had an end of contact tracing, so our contact tracing team here has ended their work, and we're also moving towards, at the end of this month, an end in universal testing. So from the end of March, the PCR testing and the free lateral flow testing will no longer be available to most people. There will be testing available to certain vulnerable individuals or settings. So, for example, individuals who are immunosuppressed will have the ability to have a PCR test to detect if they require any antiviral treatment. This is just a summary of what's currently happening with the data that we're aware of in the city. And there's just a caveat in that although testing is still available, we are aware that there has been a bit of a change in behaviour, and we anticipate that people are probably testing less than they were before as we move towards April. But what we have seen, as you can see from these charts, the one on the left particularly is the one that shows with the orange line are Pillar 2 community testing cases, and the Pillar 1 are the hospital testing cases. And you can see from that large peak that we had in January, and then as we came down from that peak in January, and we've just recently had a little bit of an uptick in our positive cases. It needs to be viewed in caution because of our uncertainty around changes in testing behaviour, but this is something that is reflected nationally and also seems to be reflected in hospital admissions as well, in that they do seem to be increasing slightly, and also reports that I've just seen around NHS staff absences for COVID increasing as well. So it does seem to fit with a national picture. The next slide, please, Lynn. And when we look at the information we have on the positive test that we do have, we can see that they're fairly well distributed. As you can see, these are different age bands with different colours, and you can see that actually over the Christmas and New Year period, each age band actually behaved quite differently, but at the moment there does seem to be a trend upwards in all of those age groups, including the over 60 age group as well. And then this data that we have is taken from the ONS survey data. So this is a survey where kits are posted out to the population without symptoms, and they're asked to test at home and send them back. And this sample means that we probably get our best idea of what's happening with the transmission of COVID within the population. And we can see that there was a declining prevalence of the virus. And we can just see that we started to see in the latest data a little bit of an increase in that. So the latest data is estimating that 1 in 25 people in England would actually be testing positive. And that, with the ONS data, we're always a couple of weeks out of date with that data. So that data is up to the 5th of March. And you can see that all of these different bits of evidence are giving us really the same story, that we are on a slight increase at the moment. Thank you. So what we're expecting over the coming months, we are looking, as I said, for the end of universal testing at the end of this month. And that will mean that we no longer have this detailed data of what's happening with age groups and particular groups within the city. But what we do have is the information around hospital admissions. So individuals admitted to hospital will still need testing to some degree. The ONS survey will be continuing, but we believe that its size will be reduced. So that will probably mean that we'll see those data estimates at a regional rather than a Derby City level. And as you know, over the period of the pandemic, the rates across the East Midlands have varied quite considerably. So we'll get some idea of what's happening, but it won't be as precise by any means as what we've currently got at the moment. Vaccination is to be rolled out further, so we've got a second booster dose for those who are judged to be most vulnerable to infection, so the over 75s, residents of care homes for older people, and people who are immunosuppressed who are over 12 years of age. We've also got the initiation of the first dose for healthy 5 to 11-year-olds, and that's starting shortly with a particular focus on promoting that over the Easter holidays, so that because it won't be delivered in schools, this is very much for parents to take children to the vaccination centres and to the places that they've received their own vaccination. The first, second and the booster doses still available, so if people haven't yet received their full dose or haven't received any vaccination, it's still possible to receive those vaccines. They're still available. So we anticipate an increasing spread in the short term, which is what we are starting to see. We do certainly hope to see that decrease over the summer months, because we will all be mixing outdoors. Ventilation is much greater when we get to warmer weather, and we hope to see a seasonality in the virus. And we do know that there is a good level of immunity that has built up within the population, both through vaccination, but also through the large numbers of infections that we've had over the winter period. But even having said that, we do anticipate that as we move towards the autumn, that we will see a further increase. And that's both around seasonality, but also around waning immunity as well. And we do anticipate at some point that we will see at least one further variant. And there's a lot of uncertainty about that. That could be a variant that is less severe in the clinical symptoms. It could be a variant that's more severe. It could be one that is better evading the antibody response from the vaccination. So there's a lot of uncertainty about that. But we do just need to bear that in mind, that will come at some point. Next slide, please, Linz. So that's the update on COVID. And just to update on the Health Protection Board. So for those of you with long memories, we have a Derby and Derbyshire Health Protection Board that was established at the same time as the Health and Wellbeing Boards in the city and the county, and reports to both boards. And it's a joint meeting whose purpose is to provide assurance to both the Directors of Public Health, but also to the Health and Wellbeing Boards on the management of health protection in the area. Over the period of the pandemic, we've moved towards having a COVID Health Protection Board. And we had one meeting of this Health Protection Board in July 2020, but haven't had a meeting since until last week. So we re-established the meetings from last week. We're reviewing the terms of reference, because what we are looking to do is to have that board reporting into the integrated care system, as well as into both of the health and wellbeing boards, to give that greater connectivity as well, which I think is a really, really positive thing. And we're also going to be meeting every other month. Previously it was a quarterly meeting, but we do feel that every other month is needed to start with, and then we'll see how the work's progressing. So we discussed the key priorities that we needed to cover over the coming year. And those priorities are infection prevention and control arrangements, which relates to how we manage this, particularly within the community, which has been such a large area of work for us during the pandemic. Screening and immunisation programmes, health protection within complex settings, and also a consideration of COVID. So discussions at the COVID Health Protection Board as to how that board will meet and whether we will merge those areas of work into the overarching Health Protection Board. So that's a discussion that's ongoing at the moment. So very happy to have any questions on any of that.
Thank you, Robin, and thank you for the work that you've done all the way through this. You've been absolutely marvellous. How you keep that smile on your face, I just do not know. But it's been great working with you. I sit on the COVID outbreak board, and whether it's been daily, weekly or fortnightly or eventually monthly, it's been intense working, and that information has gone out to all our health colleagues and to all our councillors to ensure that people were kept up to date on our COVID situation and the work that's been done. So can you please pass our thanks on to your team for the work that they've done. I know it's not just you. I know that you've got a fantastic team behind you. Thank you. Are there any questions for Robin?
Well, it's just more a bit of advice. I do the NSO survey where they come and take your blood and the PCR. And I've had 2 emails recently saying, just in the last few days, saying that they are going to extend the study for some considerable time now. So it's not going to end shortly. They seem to be looking quite a long way in advance, and by the looks of it, the sort of one of the letters sort of implied that it was up to 4 years ahead. So it's not something that's going to go away, but we do need all this information to reassure us that things are working. Thank you.
Okay. Any response required, Robin?
I guess I'd just say I think there's an intention to move surveillance towards very much how we manage the surveillance of other conditions. So, for example, with flu, there's continued surveillance every winter where a sample of GP practices will swab people coming with respiratory symptoms. So I think there's a lot of consideration around how we can maintain surveillance, but to do it in a slightly scaled down way that still gives us the information that we need. But yes, good to know that you've had that letter through.
Thank you, Robin. Any other questions? Yes, Councillor.
Hi. So with the rollout of the vaccination to the 5 to 11-year-olds, actually not speaking as a councillor, speaking as a mum, I haven't heard very much about it from the school. Is there? I know you work really closely with the schools because I get loads of letters from you through the school. What is the plan for the communication to parents for that? Because, like I said, I was aware it was coming, but I wasn't aware it was so soon. Yeah, thanks.
Thank you. So this programme is specifically not going to be delivered through the schools. It's going to be delivered through the normal vaccination programme, so where you will have gone to receive your vaccination. I'm aware that we have Jane in the room, so Jane may know a lot more about any plans for communication.
I probably can't help out a lot more than that. I've been sitting on some of the national calls, but it is that the invite letters will go out to parents as they have done for all the other cohorts, inviting them in and asking them to book through the routine booking routes into the main vaccine centres. They've made a conscious decision not to deliver to that age group in schools because of the very reasonable requirement that the majority of children would be wanting to have parental support because it's an intramuscular injection. Every other vaccine that we deliver in school to that age group is a sniff up the nose for the flu vaccine, so we don't do any intramuscular at all. So yeah, it'll be coming out. It will be coming out. It'll be on an invite basis into the main vaccine hubs.
So as before, the national booking system.
We'll get a text message to say it'll come, like we did before.
So the date isn't with us yet for when it's going live, and then it'll come out via the national team, and there'll be quite a lot of comms publicity about it. So as I was driving in today, I could hear Nikki Kanani, who's the national director on this, putting something out onto the local radio station then. But yeah, they'll be making sure that it's widely publicised and that the booking system is as easy as possible, and that there's also quite a lot of preparation gone into the vaccine sites to make sure that the vaccine sites are suitable for, friendly, have got preparations to make sure that they can accommodate young children's needs.
Okay. Any further questions? In that case, thanks again, Robin, and we'll move on to where are we? Item 7. And its challenges across housing and homelessness and their impact on wider determinants of health. So over to you, Martin Brown.
Thank you very much, Councillor. I I've chosen to start off with this slideshow just because it's something that a paediatric consultant chose to share with her peers last week, because she felt it was a good demonstration of the impacts of better collaboration between paediatrics department and council services. And we are doing similar work with the respiratory health department, Impact Plus programme, and from this morning we were speaking to renal department at the hospital as well. So in this particular case, a paediatric patient has brittle asthma, is making use of the high dependency unit, high levels of asthma treatment, and additional inhalers just to maintain the symptoms. On a wider conversation around the home environment, the mother did indicate that there were water leaks at the home and mould in the rooms, and a positive allergy test was received with regard to moulds in the home. Next slide, please, Linz. We went and had a look. The referral was made through a simplified referral process, so it makes it a lot easier and a lot quicker for clinicians to refer into our services. There were a lot of leaks in the home, roof leaks, leaks under the sink, leaks around the bathroom, a lot of mould. The one on the right is not particularly clear, but that's mould in a bedroom and a lot of mould around the bed head area there. Next slide, please, Linz. Again, other examples of mould and leaks around the house. Next, please, Linz. The heating was poor, not capable of allowing the home to be properly heated. That combined with poor insulation meant that the family had to spend limited resource on supplementary heating. Next slide, please, Linz. That also causes problems with trip hazards, overloading of unsatisfactory, unsafe electrical installation. And there were other risks in the property as well. The picture on the right, the only thing that's stopping that window opening fully is a very old bungee cord holding that. It's a very low windowsill, and a child could easily, or an adult in fact, could easily fall from that window and that straight onto the pavement at the front of the house. The patient, but also the sibling, and risks for the parents too. Damp and mould linked with the inadequate heating, the lack of loft insulation, poor draft proofing, and then the leaks as well. Next slide, please. So just a quick summary of progress. The referral come through. The private landlord had failed to respond to the tenant's request to address these items. Our housing standards officers have attended. They've served schedule on the landlord for compliance, and this particular landlord has started quite quickly. He has installed smoke detection alarms pretty much immediately. All the roof leaks have been sorted. Works to the mould and other defects there are either complete, underway or scheduled. Next slide, please, Linz. And I think this was the main point that the paediatrician wanted to get across, is that even though these works have either been carried out relatively recently or some are still awaited, there has already been seen a significant improvement in the patient, with no acute severe wheeze, no further wheeze when presenting to the children's department. So it's a message she wanted to try and get across to encourage more quality conversations by her colleagues with patients, to try and make use of a simplified referral route into council and community support and services that is available across the wider determinants of health, not just housing. Something I think we're all particularly concerned about at the moment is financial hardship and people living in cold homes, unable to heat those homes because of rising energy costs. The National Child Mortality Database identifies poor housing as one of the top risk factors associated with the inequalities that result in children's deaths. And we know from work that our public health colleagues have carried out that areas of the city with the most cold, damp housing correlate with those areas of the city that also have the highest rates of emergency admissions for respiratory health and emergency admissions for childhood asthma. So there are many clear links and evidence that unsuitable or unsafe housing or lack of a home all have significant impacts on population health, particularly our most vulnerable residents. The population health management development work that Alison's leading, PLACE agenda, joined up care, the adult social care white paper, the levelling up agenda, all emphasise the importance of our home living conditions in the context of better integration between health care and housing. In the next few weeks, public health colleagues will be reporting on a couple of very big pieces of work that have been carried out. They've been carrying it out over a couple of years, but that is because COVID delayed some of that work. There's a health impact assessment of housing condition in Derby, which is an analysis of housing condition and hospital data. There's also a very detailed analysis of private rented housing conditions in the city. Now, locally, we've long held concerns that conditions in the private rented sector in Derby are significantly worse than the English Housing Survey would suggest. It took a while, but we eventually won some funding to enable a physical survey to be carried out of more than 100 private rented homes in areas of our city with the poorest condition housing. That survey is complete. Public health colleagues are very close to reporting on the final analysis of that piece of work. That should be out by the end of this financial year. What the indications are at the moment is that we were right and that conditions indeed are significantly worse in private rented housing than the English House Condition Survey would indicate. That means that there's going to be a lot of work to do to pull together an effective intervention strategy to try and help some of our most vulnerable people living in the poorest housing conditions. Therefore, what this report is seeking is a commitment from the Health and Wellbeing Board to promote and enable better collaboration and integration across the health, care and housing sectors, and in so doing to approve the establishment of a health, housing and homelessness subgroup to provide that strong leadership that's required to deliver this agenda. And that's it. Thank you. Thanks, Linz.
Thank you, Martin. Very informative as usual, and raising issues that we know are there, but we've now been able to have the ability to look at in detail. And as housing is part of my portfolio, I am really wanting to see that report as soon as possible so that we can move on these. You didn't mention that we're looking at trying to establish a licensing area within the city?
What we've got to do is come up with an intervention strategy, and I think without doubt, it's obviously a member decision ultimately, but I think without doubt selective licensing will form a part of that strategy. MHCLG, as they were at the time, have carried out an independent review of selective licensing nationally, and what their findings are reflect very much what, as housing professionals, our opinion too would be, in that selective licensing is a useful tool, providing it becomes, or providing it is part of a wider package of interventions. If you look at the mapping, the areas of our city in the most deprivation, with the most child poverty, with the biggest gaps in healthy life expectancy, with the poorest housing, all overlap. And there's a necessity that we go into an area and try and tackle the wider inequalities. No single intervention will solve this. Selective licensing on its own in an area will not solve the housing issues and will not solve the wider inequalities in that area. It has to be part of a wider package. One of the things that that the MHCLG work identified is the critical importance of enforcement. Selective licensing, you're allowed to charge a fee for selective licensing. That fee is quite tightly controlled as to what it can be used for and what it can't be used for. Enforcement under Category 1 of the Housing Act, which are they're called HHSRS hazards, which are the main hazards that would impact someone's health. That is excluded from being dealt with under the selective licensing fee. So an enforcement programme is necessary to really target the rogue landlords. Selective licensing on its own will do a lot to work with the more compliant landlords who will inevitably be the first to apply. They'll inevitably be the first to comply with any conditions that are attached, and many of them will be keen to raise the standard of their property. But they are not the problems in that area. It's the rogue landlords, the less compliant, the less interested, whose houses are the worst and whose houses are having the biggest detrimental impact on their occupants. So we need a package of interventions.
Thank you very much for that, Martin. It's good to have that explained in public so that we are aware of some of the poor housing conditions. We are looking at tools that can be used to improve those housing conditions, and we need those landlords to be on board with us. Otherwise, we would have to take a judicial route to getting those properties improved, and we don't want to do that. So thank you. Any questions? Magnus.
Thank you, Chair. Firstly, apologies for my lateness. I was travelling up from Burton and it took a while to get here. And for those that I don't know, my name's Magnus Harrison. I'm the Interim Chief Exec at UHDB. Just really interested in what you were saying about the broader picture about people and the ill effects on their health. We have 1,200 admissions a month at the moment that bounce back in. So I just wondered whether it's worth a conversation about thinking whether there's another way of looking at these readmissions. And the way we usually send people home, we use a set of physiological criteria, but that's all we use, and we don't use the wider determinants of health or a broader picture for that particular individual. And I've just signed UHDB up to a national project to look at a big data piece about people presenting with respiratory illness, adults predominantly. And it might be that it will all feed into this, but it was really interesting, and thank you.
Can I respond, Councillor? That is really interesting. I love the Marmot quote, which is, why keep sending people back to the same conditions that contributed to their poor health originally? And we do. We keep doing that. And from a housing perspective, we see those conditions and wonder why people are returned to them. Becky Harrington has been absolutely critical in driving all the work that we've done with, say, with respiratory department and Impact Plus and so on. I'm very aware Becky's leaving at the end of this month, as do I, and I think we probably have been two of the main people that have been driving this work. So I think it worries me a little, but there could be a gap there. I'm hoping to meet, is it Elaine Andrews? I'm hoping to meet Elaine next week and make some introductions before I go, but it would be interesting to maybe if Lindsay could share your email address, maybe I could drop you an email and we could have a quick email exchange before I do go, because it really does feel to be something we should pick up on and not lose.
Happy to.
Thank you for that, Magnus. It's good to talk, as they say. Okay, any further questions? In that case, then, there are 3 recommendations that need to be approved, Are you, or is there anybody against approving those recommendations, 2.1 to 2.3? Okay, thank you. In that case, we'll accept those. Thank you, Alison. We now move on to the Health Watch report on experience of health and social care services.
This was to do with homeless or people living in temporary accommodation, Chair. Well, to give you the background of this, in the winter of 2019, Health Watch Derby and Health Watch Derbyshire conducted a joint project around the experiences of health and social care of people who are homeless or living in temporary accommodation. Due to the global pandemic and subsequent changes in services, the report was delayed, and upon completion of this report, there had been many changes within the health and social care. In the spring of 2021, the public health team at Derby City Council contacted us to discuss homelessness in Derby. There were a few areas of change that the team were interested in gaining an insight to from the public, which were GP services, dental, substance misuse, mental health, and hospital discharge. Now, it took a bit of putting together, because obviously talking to people at such a stage was very difficult, but with a bit of team working, and also with help through the Homeless Liaison Forum, which I must acknowledge thanks for what they did to help us, we were able to conduct a survey in mid-August for 3 weeks last year. The results of that, it was done online, although there were paper options available for people, but most of it was done online, which probably gives us an indication of the age of the people that returned the questionnaire. There were 51 respondents, and 50% of those were in the 18 to 24-year-old category. 75% of them were male as well, which is quite a telling thing about homelessness. Also, that 75% of those people were actually somewhere in the system, in the shared housing accommodation, which was again quite revealing. And to cover what the results of the study was, with regards to GPs, most of the respondents were registered with a GP, and around 50% had used GP services within a year. The overall service and support offered was deemed good, but improvements could be made to access and waiting times. With regard to dental, less than a third said they'd used a dentist, and again, this is quite common with people, particularly young people with fairly good teeth. They don't actually need the services of a dentist, so there's less demand. The sentiment was split about whether the services met their needs. The overall service was good, but improvements could be made around the changing or cancelling of appointment times. There appeared to be general confusion around dental services provided. So this is an area where we think there needs to be some improvement to get the knowledge out there as to how people deal with obtaining dental help. Substance abuse, under a third of respondents have used a drug or alcohol service within the last year, and these were split quite evenly over several providers. The sentiment was split as to whether the services met their needs. The support and overall service received was good, but improvements could be made around face-to-face appointments. With regard to mental health, approximately 20% of the respondents used mental health services, split quite evenly over several providers within Derby. Just over 50% of the respondents did not feel the service met their needs. There were individual comments left regarding what worked well. However, over half the comments around improvements were about waiting times and number of appointments. So that's indicating that there isn't enough of the service there for them. Hospital discharge. A third of respondents have been discharged from hospital within the past year. So, and 3/4 of them were at the Derby Royal Hospital. Most respondents had felt ready to be discharged and that it had been clearly explained to them. However, the majority of respondents did not feel that they had appropriate support arranged for them before they left. Awareness has been raised across the services and responses received from the Senior Commissioning Manager, Primary Dental Care Services East, NHS England, and NHS Improvement Midlands, and Area Service Manager for Substance Misuse, Derbyshire Health Care, NHS Foundation Trust. The purpose of the report is to provide the Health and Wellbeing Board with an overview of what we found, of the experiences of the health care services for people who are homeless or living in a temporary accommodation in 2021, and to ensure that the Health and Wellbeing Board is aware of the report and the findings which support the Health and Wellbeing Board in its role in improving the health and well-being of the local population and reducing health inequalities. Thank you.
Thank you, Steve. An interesting and informative report. One question I would like to ask, and I'll tell you why. Mental health services for those that are rough sleeping, there is a specialist nurse there that provides mental health support for those that are street homeless. Was this report aware of that?
No, not as such. The only part that I can refer to is the fact that there was a GP homeless service based on Wilson Street. And beyond that, I wasn't aware of what you've advised me of now. Okay,
Only there has been specialist services for street homeless, and if this does not include the street homeless, then I'm concerned, but I would like to see those services expanded for those that are in accommodation as well.
Yeah, well, looking at the breakdown of the people who responded to the survey, most of them were online and had help from the Homeless Forum to do it. Right. And only one of them admitted to being entirely homeless. So that there is an element of that needs to be considered further. I think that's a good point, Chair.
Okay, thank you very much. It's all right. I am aware of the issues. It's just I wanted to get behind the detail.
Yeah, I understand that.
Okay, any other questions? In that case then, we are asked to consider and note this report. I shall be taking this report further So
Yes, the report itself is a lot more detailed than this. So
Yeah.
I couldn't. I didn't want to do the information overload on anybody because there's a vast amount of information flying around.
Okay, well, I'll take this further, and hopefully it's useful information that we can use with mental health colleagues, with GP colleagues. I have a little concern around some of the thoughts of people that responded around GP services, but I shall make sure that this goes further and wider.
Lovely,
So,
thank you.
Thank you. Okay, we then move on to Health and Wellbeing Board Development, and it's you, Alison.
Thank you, Chair. So, yeah, just going to give a fairly brief, I guess, update in terms of where we've got to in terms of Health and Wellbeing Board development and some of the next steps. So I think most of you, I think everybody in the room has taken part in some of the development sessions that I think started in July of last year. I think we had one July, one September, and one again in November in terms of developing this board. And through those sessions, I think we've agreed a number of things for the Health and Wellbeing Board. Firstly, it should continue to play a significant leadership role within the city, but it must have a clear vision, purpose and set of outcomes. And we also agreed that they needed to be aligned with those of Joined Up Care Derbyshire and also the City Partnership Board. As part of the process, we agreed a set of population health outcome indicators that again are shared with Joined Up Care Derbyshire. I think probably one of the clearest things that came out of the development sessions was the want of the Health and Wellbeing Board to very much focus on prevention and the wider determinants of health and the contribution of those to the population health outcome indicators that we've identified. And again, I think probably one of the other key things, and I know in conversations that certainly Roy and Meryl and I have had, and I think also came through the development sessions, was the want of the Health and Wellbeing Board to be more proactive and active and drive action against outcomes. But also that we need to better connect and collaborate with other boards and groups within the city to help us achieve those population health outcomes. So I guess that's pretty much where we got to in terms of what we want for the Health and Wellbeing Board to do. So taking that really into how it wants to work. So I think we've agreed that we want to be focused absolutely on achieving change in those outcomes through overseeing and driving action. Again, focusing on prevention and the wider determinants that will be data-led, be active and proactive, that will operate in a manner that's open, honest and constructive. And I think particularly working collaboratively and in partnership, and I think it's come through in very much through the discussions that we had in the Health and Wellbeing Board, but also through kind of many other groups and conversations I've been in over the last couple of years, that actually the collaboration and partnership working that's been experienced through COVID has been really positive and is something that we absolutely want to continue and build on. But also that we absolutely want to work with and for our communities and put our communities and local people at the heart of what we do. So in, I suppose, response to that, and actually some of the discussions that we've just had with Martin, for example, I think we've thinking of some additional members to the Health and Wellbeing Board to reflect kind of the way we want to work and those kind of population health outcomes that we want to focus on. So we're proposing the addition of the Deputy Chief Executive of the Council who covers communities and places. I think we've probably got amiss at the moment in terms of kind of our environment and kind of physical space of the city. Then to cover our housing and homelessness component, which builds on the establishment of that housing and homelessness group as a subgroup of the Health and Wellbeing Board, bringing in colleagues from Derby Homes, but also the strategic head of strategic housing for the council to cover those elements and link that areas of work in. Also bringing in and kind of as part of the better linkage and collaboration with the place, which is helpfully within the city, kind of on the same footprint or more or less. So working with Derby Place Alliance or partnership as it will become. And then also I think we had, I think at our last meeting in or kind of formal meeting in July, we had Derby Poverty Commission come in and have a conversation, and I think given some of the conversations we've already had today and kind of the impact of poverty and wealth on health and well-being and the work of the Poverty Commission, I think it'd be relevant to have them linked in kind of formally to the Health and Wellbeing Board, and then of course kind of our integrated care system representation on the Health and Wellbeing Board, which Vicky is ably representing at the moment. So they're suggested additional members, Chair. I thought you were about to press the button there, Chair, to come in. No. So I guess further next steps are around reporting and relationships. So we absolutely must effectively link and work with the integrated care system, but probably most particularly the integrated care partnership. As I've mentioned, our Derby Place Alliance and the Derby Partnership Board. I think there's work to do in terms of working out what those relationships are, and I know that's part of kind of phase 2 of the ICP development. So I think we just need to do some thinking in terms of what do those relationships and reporting look like. And then also to build on and work with existing groups. I think as part of our development work, we did identify a number of, I think, already established groups that are taking forward a great deal of work in some of the areas that relate to our outcome boards. And I think it's kind of linking those in and working out kind of how we relate to those kind of much better than we do now. And where appropriate, establish new groups, and I think we've already done that today with the I think agreement to establish the housing and homelessness group as a subgroup of this board. So key actions that I'm hoping to have done for next meeting. So kind of revised terms of reference to get us into place for, because we want it. What I haven't said is that I think we were clear through those development sessions that we wanted the board to be operating in a different way from the new financial year. So as we move into 2022-23, so we'll put in place terms of reference for the start of that period, but recognising that they may need to kind of flex and be updated as we kind of further establish our relationship, particularly with the integrated care partnership. Kind of do a piece in terms of mapping those groups and boards that we think the Health and Wellbeing Board should relate to, and draft a subgroup report, reporting and governance arrangements as well that kind of sit around that. So that's the proposal for next time around, Chair. So really that's the end of that, really, just to say that I think we are recognising the work that we've done through the development and looking to take that forward as we move on from our next meeting. Thank you, Chair.
Thank you, Alison. And one of the challenges we've had as a Health and Wellbeing Board is where do we fit in with the new integrated care system. So what we're trying to avoid as a board is duplication and having the integrated care system discussing the same things as we're doing as a Health and Wellbeing Board. So to make it a more effective and purposeful board for the city, to deal basically with the local authority side of issues, but linking clearly with health outcomes across the city. And I think we're moving in that direction. I'm hoping that by next time we meet, that we will have those terms of references. Those linkages with health are already established, and if there's one thing that COVID has taught us all, is we can't do it all on our own. We have to work together, and relationships between local authority and health have never been better. That's my opinion, and of course I'm right. But no, it is true. We are working together better than we've ever done, more effectively than we've ever done, and we need to continue to do this. Are there any questions? And are there any objections then to increase the membership of the Health and Wellbeing Board in line with the recommendations that Alison has made? No objections? Okay, in that case I'll take it as agreed. And then the next item on our agenda is the promoting prevention and addressing the wider determinants of health from an acute trust. So that's Becky.
Yeah, I think we're still waiting Becky. I know Becky was coming from another meeting,
Right.
Chair, and so was, I think, probably not getting here till about past. So
Okay, well in that case, can you then do the pharmaceutical needs?
assessment, which, yes, is very exciting. So the Health and Wellbeing Board is required to prepare or ensure that we have prepared and publish a pharmaceutical needs assessment for its area every 3 years. We should have produced one, or the expectation originally was that we would have produced an updated one kind of within the last year, but obviously with COVID there was a deferral of that nationally. The requirement now is that we publish an updated pharmaceutical needs assessment by the 1st of October this year. We're proposing, as we did last time, so our first pharmaceutical needs assessment that we published in 2018, we did jointly with our Derbyshire colleagues and produced a pharmaceutical needs assessment that covered both Derby and Derbyshire, but included a detailed component for Derby City requirements. So we're proposing to use the same approach again, and this time around our Derbyshire colleagues are leading on the production of the PNA. We've established a steering group, or kind of put in place the steering group to oversee the production of the pharmaceutical needs assessment, to ensure that we've got the appropriate input into that, but also we ensure that we cover all the minimum requirements and expectations of a pharmaceutical needs assessment. So that's now in place and currently in process of preparing the pharmaceutical needs assessment. There is a requirement that the draft, there's kind of requirements that certain colleagues, organisations and community are included in the development of the pharmaceutical needs assessment, but there's also a requirement for a formal consultation period of 60 days. So what we're proposing is to have a draft of the PNA up and ready by June, with the idea then that we go out to consult on that draft document over the summer period, then looking to bring that back to the Health and Wellbeing Board in September as a final version, once we've taken into account those the feedback from that consultation and amended the document accordingly. So we'll be looking to bring back to this Health and Wellbeing Board an update, probably in our July meeting, just to confirm that that's moving ahead as planned in terms of progress and consultation, and then bringing to our September board our final draft version for the review of the Health and Wellbeing Board and approval to publish the pharmaceutical needs assessment in advance and ready for that timescale of the 1st of October. So really just seeking the Health and Wellbeing Board's support to prepare the document in the way that we've done before, so covering both Derby and Derbyshire, but also to receive those updates in July and that approval within the September Health and Wellbeing Board chair.
Thank you, Alison. A quick question on the consultation. One of the things that we need to ensure is that there's no digital deficit with consultations across the city, and will there be other versions of the consultation available for those people that don't have digital access?
Yeah, I'll be working with our consultation colleagues, and I think as previously we'll be looking at making sure it's available through a range of means and mechanisms, Chair.
Thank you, Alison. So we've got 3 recommendations on this. Anybody have any objections to any of those recommendations? In that case, I'll take silence as acceptance. Thank you very much, Alison. And I think now we can move back to item 10. So,
Hi, Becky.
Are you ready, Becky, or do you need a couple of minutes? Okay.
Do the final item.
So if we do the final item, and that's an outcome of the Ofsted and CQC revisit to assess, that's a long title, to assess Derby City's progress against the local area special educational needs and or disabilities written statement of action. So who's doing this one?
Sorry, Chair, it's for information.
For information.
Unfortunately, Andy was unable to attend due to his other commitments.
So the only recommendation on the report is to note the findings, and things look like they're moving in the right direction with regard to send services, but right direction doesn't mean to say that we can take the foot off the gas at the moment. We need to keep working on these. It's important for life chances of young people with special educational needs. Are there any comments or questions? Okay, thank you. So we got the thumbs up from Becky. So we'll move back to item 10, prevention, addressing the promoting prevention and addressing the wider determinants of health from an acute trust. Over to you.
Thank you very much. Can you hear me all right, everyone? Yeah. Okay, thanks. Sorry that I've been a bit late for it. So just to introduce myself, I'm Becky Harrington, and I'm here to tell you about some population health improvement work that's been going on at UHDB. I hope you don't mind. I'm going to read some of this and refer to notes as I go along. I got my thoughts straight yesterday and just want to make sure I don't miss anything. So the first thing is just to convey how exciting I think this work is, and I hope that comes across in the presentation. These things can sometimes be a bit dry, can't they? But I've worked in the NHS for 28 years now, and this piece of work that I've done at UHDB is what I think in all of my career has made the most difference to patients, and I think truly has the potential to be transformative. Could we move on to the next slide, please? Thanks. So I just want to start with a quick recap on population health, and I'm sure you'll all have seen this before, but it sets out the top 4 causes of death, and also which are also the biggest contributors to the healthy life expectancy gap for our population, and also highlights the common risk factors shared by all of those causes of death and ill health. And that is this information is why Derby and Derbyshire Health and Wellbeing Board and JUCD have agreed to concentrate on tackling these risk factors. If you could move on to the next slide, please. This work is sort of focused on trying to address some of those from an acute trust perspective. And you'll all be familiar with these priorities that have been set. If you could move on to slide 4, please, Alison, thanks. So what can an acute trust do to tackle these risk factors, and should they do anything at all? Should an acute trust be getting involved with this kind of work? I really like this quote from the Smoking Cessation Network in Ottawa, who were sitting in a hospital puzzling over how they could get people from their city to take up treatment for tobacco dependency, when they realised that they had a building full of smokers who were actually a captive audience. Next slide, please, Alison. So that for me is why hospitals should be doing this work. The patients we have in our 4 walls, the people from our communities who are in the poorest health, and they are likely to be more motivated to do something about their poor health or their child's poor health when they're confronted by it in the way that we all are when we end up having to go into hospital, either as inpatients or outpatients. So we know as a system, and again, some of you will have seen these graphics, we know as a system that we want to tip the scales in hospitals so that we're bringing prevention into our treatment pathways as standard practice, and we're helping patients to address those wider determinants of health. And this is what the work I've been doing is really focused on trying to turn into action on the ground. Next slide, please. So Derby City Council has been funding this hospital-based role to do just that over the last number of months. And this slide just summarises the priorities of that role. And the 2 main ones are bringing a focus on prevention into our acute trust and a focus on the wider determinants of health and supporting people in being able to get help to address those. Next slide, please. So I wanted to start with a couple of examples of the outcomes and outputs of this work. I'm just going to give you a few minutes to read through those examples yourself, but they show what impact we can have on health outcomes when we help our patients to access services that address problems with housing, money, debt, loneliness and isolation. I'll just give you a couple of minutes to read those. If you can't read the one in green, give me a shout and I'll read it out. You can't see the one in green, no. It's difficult, isn't it? Sorry about that. Okay, so the second example is a patient with COPD. So these are both sort of live examples that have happened since this work began. Patient with COPD had long-term lung condition and was being seen by our Impact Plus service for for quite a long time, suffered with anxiety, breathlessness, fatigue, loneliness, financial difficulties, and was referred directly from Impact Plus into the local authority welfare reform service, who case managed and put in place visit to the property by housing services, which found the kitchen to be unsafe, provided support to make improvements, including a new cooker and a fridge. There was a benefits check done, and the welfare, most importantly, the welfare reform team identified a large debt, which was a cause of a lot of anxiety for this patient. It was a debt that she'd had for about 17 years, caused her to lose contact with her friends because every time they went out, she couldn't afford to buy anyone a coffee. So she'd become lonely and isolated as well. And the welfare reform team put support in place to restructure the debt and make the repayments more manageable, connected the patient into Age UK, and also provided some financial support from a trust fund to buy furniture. So what Impact Plus had found with this patient was that they were trying to support her to manage her own breathlessness, and they'd got as far as they could with this, and nothing was working. When this large debt was discovered to be the cause of most of the anxiety, that made the difference for this person. And as a result, she's now rarely breathless, her anxiety is manageable, finances are in better order, and she's no longer isolated. And a huge, fitting it all into that little bit of space, there's not enough to explain what a difference it made to this patient. We've been reviewing these referrals that we've been making to test them for appropriateness, and also to see whether I've been asking the question, would this patient have been able to access these services if health hadn't made a referral? And the answer I'm always given is no, we don't think this person would have found these services unless health had referred them in. So there's just a couple of examples there, and we've got a lot of examples now of and case studies and patient stories with, very similar sort of experiences. So that's sort of starting a bit at the end and telling you some of the outcomes we've had, which are really positive. If I could move on to the next slide, please. I'd also like to bring in here some evidence for why we should be bringing prevention into our acute treatment pathways. And this evidence comes from a tobacco dependency treatment service that was set up in Ottawa, going back to that slide a few slides back. The same group set up tobacco dependency treatment for inpatients. If we apply the results of their hospital-based tobacco dependency treatment programme to our own local hospital, we can see the impact here that bringing a prevention approach into our treatment pathways has on the health outcomes, readmission rates, and use of NHS services. So again, just give you a few minutes to absorb those figures, which I think are really quite amazing, actually. So this is applying the Ottawa figures to the admissions that we have in at UHDB, the number of admissions we have a year, and assuming that we get the same quit rate and all the rest of it that are seen in Ottawa. But really significant impact on patient outcomes and, of course, on their use of health services. Could we move on to the next slide, please? Thanks. So over the last 12 months, this acute-based public health-funded role has focused on these 6 elements that are set out on this slide. The remainder of the presentation, I just want to focus on mostly on the two top ones, how we can bring about prevention into our treatment pathways, and how we can help people access the help they need to address those wider determinants of health. The orange boxes, which don't look very orange on there, but the boxes labelled enablers, I also want to highlight some of those and what we need to change in our system to enable us to be able to do this work. If I could move on to the next slide, please. So how do we make prevention part of our treatment pathways? So I think there are three strands here, or certainly three that I've sort of been focusing on. The first is setting up direct referral routes from our outpatient clinics into Live Well and Live Life Better Derbyshire, who provide coached programmes of support to people to stop smoking, lose weight and move more. The second is to screen inpatients in hospital for smoking and to make tobacco dependency treatment available to them immediately. And thirdly, screening inpatients and ED attenders in hospital for harmful levels of drinking and making specialist intervention and support available to them. Those last two are both things that are now national targets for acute trusts. So having set some of this up, I just wanted to sort of highlight what we'd found, and those things I've related back in that sort of middle box to how they, which of the turning the curve priorities they relate back to. So obviously reducing smoking levels, increasing the proportion of people who are a healthy weight, improving levels of physical activity, and reducing harmful alcohol consumption. So what did I find when I tried to connect our specialties and clinicians into these services? Firstly, clinicians really want to do this. They're really keen. They've got a real appetite for it, but mostly they don't know that Live Well, Live Well and Live Life Better Derbyshire exist. And if they do know they exist, they don't know that they can refer directly into them. As a patient, understanding that losing weight is as important as taking your medication, and that being made clear by a clinician is a really powerful message and helps motivate people to take action. So how clinicians have that conversation with patients is really key. Another finding is it needs to be really easy for clinicians to make these referrals. And of course, we haven't hit it at the moment, but the more people we refer into these services, the more there'll be an issue of capacity for Live Well and Live Life Better Derbyshire. And that will become a limiting factor. If I could move on to the next slide, please. So this part, so we've looked at that prevention, and we've got a number of specialties now linked into prevention services. We've had two really large events to raise awareness of those prevention services and encourage clinicians to refer in. Those events reached about 150 different clinicians within our medicine division and paediatric division. So that's one element. The second element is connecting services in so they can support people and address the wider determinants of health. How do we do that? Again, through direct referral routes, setting up direct referral routes from our specialties to local authority and other services that are able to help. And there are some examples of where we've done that. This is much more targeted, I suppose, than the generic prevention approach that we've been talking about. So, for example, set up direct referral routes for respiratory patients into housing services. Again, direct referral routes to between some of our diabetes services, particularly those for that are working with some young people who have, young adults who have particularly complex lives, and referring those into local area coordination, which has helped those people to reduce the number of times they reach crisis and end up in ketosis in the hospital. We've got examples of referring families of a family of a child into welfare reform team and helping them with financial hardship. And there's been some excellent work going on in our emergency department, working with people who attend ED 50 plus times per year, so around once a week, and referring those people into local area coordination, and that's had a massive beneficial effect and a huge reduction in their usage of ED. So we've got examples of people who have been turning up at ED 50 plus times a year. They've had an intervention with the local area coordinators, and their attendance has gone down to once or twice a year. So really seeing some significant benefits. So again, setting up these referral routes, what did we find? Similar to the prevention services, clinicians really don't know that these services exist. When they find out about them, they just want to bite my hand off and refer into them. They really don't need convincing to use them. The benefits are obvious to them. Housing, local area coordination, and welfare reform team, they all offer invaluable services for our patients. I'm sure there are other services that I'm not aware of and haven't found out about yet. My experience has been that these services, these local authority services, really want referrals from the hospital, as these are the people who will most benefit from them. So local authorities, both of them have been absolutely brilliant to work with. They're really keen to take referrals from the hospital because they're concerned that people are not accessing, the people who most need their services aren't able to access them at the moment. And in effect, by getting referrals from health, we're identifying those whose health conditions are being exacerbated by those wider determinants. Again, the conversation the clinician has is critical. Training is needed to skill people up to do this. And the other really important finding of this is that we have to, as an acute trust, it's imperative to have that single point of contact into each council, because no clinician can navigate all of those local authority services. So a single point of contact into them is critical, and this really can't work without that. Again, a potential limiting factor with this will be capacity. So capacity within housing services and local area coordination and so on. If I could move on to the next slide. A very quick word on enablers. There are loads of enablers across the system. Some of them are listed here. The couple that I really want to single out are the single point of contact. That already exists within both councils, but the sustainability of that is key to enabling this work to continue. So having one route into multiple services, and that one route not being a signposting function, but much more sort of hand-holding, helping to unpick what's going on for that particular person, and support them in accessing the help that they need. The other one that I'd really like to draw attention to is something that I hear regularly from clinicians. They really need it needs to be easy to make referrals into these services. They really need to be able to do it at the press of a button and not fill out lots and lots of forms, because there just isn't the time in clinic to do that. So I've worked on an IT solution which is in development. Been working with our IT department, and that will be ready to launch soon. The main issue, obviously, with all of this in the longer term, will be the capacity of these services that we really want to refer into and benefit from referring into. Could you move on to the next slide, please, Alison? So just doing a check back to those priorities that have been identified in turning the curve, and the action that has been taken against each of those priorities. Again, I'll just leave you to have a look through that. Okay, so if I could move on to the next slide. So at the same time this work has been progressing, there's been a lot of focus on using data to identify people in our communities who experience health inequalities. And it's just a plea, really. We do need to do this work, but at the same time, we need to continue with the work that is already happening on the ground, the work that I've been describing here. Linking data sets enables us to find specific cohorts in our population who we want to target extra resource into. But once we found them, we still then need to make some kind of intervention. It's likely that those interventions will be smoking cessation, weight loss, physical activity, help with housing, help for people on low incomes, etc. The data analysis can take a long time, and as one clinician pointed out to me recently, we can easily identify people who are disadvantaged. We just go down to the food bank. So a plea really to continue with this at the same time as we are crunching the data to find those specific cohorts of people suffering particular disadvantage. Next slide, please, Alison, thanks. So just wanted to conclude on the impact that having an acute-based role has, that is focused on prevention and those wider determinants of health and connecting all those parts of the system up. There's just a few sort of bits of feedback here about the role. Anything in blue is from a clinician, anything in green is from one of our partner organisations or partner services at the local authority. So I'll just pick out a few. Time and dedicated resource is needed to spread the word and the practice such that it becomes the norm. My current subspecialty interests include conditions which are largely preventable with treatment of nicotine addiction and management of obesity. Just by our smoking interventions alone, it's staggering to see how many lives we could save and admissions we could avoid. The role has sought to instigate change across our systems and has been genuinely successful in doing that, in large part because it has been a dedicated role. And last one, the changes that have been implemented are extremely beneficial to patients. If I could move on to the next slide, please, Alison. So finally, a snapshot of what the last 12 months has taught us. Firstly, patient outcomes have improved significantly. There are real tangible benefits to their health. We've got case study evidence, and we're also doing an evaluation of the initiative that links our respiratory service with housing. Second, there's huge potential to expand and a huge appetite from clinicians and the wider system to do so. There's loads more to do, but it does need a dedicated resource to get this work done. As we expand the demand on local authority services, housing prevention and local area coordination, that that demand will go up on those services. So the question I'll leave you with is how the system decides to distribute funding to get the balance between treatment and prevention right. Thanks very much for listening. I know I've overrun a little bit, but if anyone has any questions, I'll be happy to take them.
Thank you, Becky. You could be writing my election manifesto for me with that presentation. Local area coordination is a success. It's there, the evidence is quite clear, and I've been banging the drum about that one for years. The big thing that you put up there is capacity, and one of the things that the local authority is limited in capacity. So we need partners on board. If we're going to move to a prevention agenda, then we need partners to push their funding onto us so that we can deliver that prevention agenda. It will be cheaper for them because they will not be getting the clinical usage that is required when people meet that point where they just can't cope with what's going on. So, yeah, really interesting. I mean, when I took over this responsibility, we'd only got 10 local area coordinators in the city. We've got 17 now. They are linked in with clinicians, but because of capacity issues, we're only able to deal with a certain number of people per local area coordinators, so capacity really is an important issue. Livewell was, the service on Livewell was rock bottom when I took over, and I've managed to put the funding up on that. The successes from Livewell and moved up more Derby have been immense, but again, there's still a capacity issue around that. We know there's a lot of services within health that are around smoking, obesity, drugs and alcohol, and if they're in health, then those patients eventually come out into the community, and we need those services there. So, the integrated care system hopefully will get round it. And the important one you mentioned was single point of contact. And it is one of the things that the local authority has learned during COVID is having the hub that we got at Derby City where people can refer into as a single point of contact is of real benefit. And if we could duplicate that with regard to health services referring in rather than people about COVID, then I'm sure we're on the winner there. So, as I say,
Yeah.
you could write my manifesto. Thank you. Any other comments? Okay, well, can we... Sorry, Vicky.
Sorry, just belatedly from me. Sorry, I was a bit delayed in responding then. So I just want to say thank you for that. I think it's a really great presentation.
Thank you.
And I think it is absolutely everything that we've been striving to do. And I'd separately perhaps pick up outside the meeting, but I think we need to take the opportunity to kind of showcase some of the work that's happening in UHDB within the broader partnership, but particularly within Joined Up Care Derbyshire, because I think lots of the other partners are not aware of some of the work you've been doing, and it would be a good opportunity to share some of that learning and encourage that kind of action in other providers.
Sure.
Thank you.
Thank you. Anybody else? In that case, thank you very much. I'll have a conversation with you outside of this meeting, Becky, but as far as I'm concerned, that's been a really good meeting this afternoon. And if the Health and Wellbeing Board is moving in this direction, I think it's the right direction to go. So thank you very much for your attendance, and we've finished before time.